Welcome. Today we're unpacking the truly fascinating neurological world of agnosia. It's one of those conditions that really makes you stop and think about the very nature of how our brains construct reality. So, let me paint you a picture, a clinical puzzle. Your patient is sitting right in front of you. You hold up a simple key. Their vision is perfect, 20/20. They can describe its shiny metal, the little teeth, the circle at the top. But when you ask, "What is this? What's it for?" you just get a blank look. You see, there's a huge disconnect happening between what they're sensing and what they're recognizing. And that condition, right there, is called agnosia. Now, here's the thing you've got to get. This isn't a problem with their eyes. It's not the optic nerve. The raw data, the signal, is getting to the brain just fine. The breakdown is happening later, in the processing centers. It's like the brain receives the file, but it just can't open it to see what's inside. It can't link that signal to the memory that says, aha, that's a key. You use it to open a lock. All right, here's our game plan. We'll start with the basics of what agnosia is. Then, we'll walk through a real-world clinical case. Meet a patient named Mr. Davies. After that, we'll zoom out to see the whole agnosia spectrum. Talk about how to tell it apart from other conditions, and then, of course, we'll wrap up with a high-yield review and a quick quiz to make sure it all sticks. Okay, to really get a handle on this, we've got to move from the abstract to the concrete. So let's step into the clinic and meet our patient, Mr. Davies. His really puzzling case is going to be our guide into the world of visual agnosia. So the case starts, like so many do, with a pretty vague complaint from a family member. He's just been acting strangely. As a clinician, your mind should already be spinning, right? What's on your differential? Could this be the beginning of dementia? Maybe it's a language problem, an aphasia? Or is it something else entirely? And this is the moment in the exam where the light bulb goes off. His vision is perfect. But you show him a pair of scissors and nothing. He's stumped. But then, and this is the kicker, the moment you put those same scissors in his hand, the recognition is instant. "Oh, these are scissors," he says. That one single finding is a massive, massive clue. It tells you the problem isn't everywhere. It's specific to one sensory channel, his vision. So let's connect the dots here, just like a good clinician would. Step 1, sensation is intact. His eyes work, his sense of touch works. Step 2, recognition is the problem. He can't access the meaning. Step 3, the problem is specific to vision. This isn't a language problem because he named them when he felt them. That logical chain leads you straight to the diagnosis, visual agnosia. Now, we can get even more specific. Visual agnosia isn't just one thing. There are two main flavors. And the way you tell them apart is with a super simple test you can do right at the bedside. You just ask, "Mr. Davies, can you draw those scissors for me?" If he can't draw them, it's apperceptive agnosia. His brain can't even form a stable picture of the object. But if he can draw them perfectly, yet still can't tell you what they are, that's associative agnosia. The picture's there, he just can't connect it to its meaning. And this flowchart just nails the pathophysiology. In Mr. Davies' case, with associative agnosia, the visual data comes in. The brain forms a perfect picture. The secondary visual cortex is doing its job, but then it hits a dead end. There's damage in the occipitotemporal cortex, which is part of the brain's what is it pathway. That damage severs the connection between the image and the brain's mental library. The picture is seen, but the label for that picture is lost. So we've talked about objects, but agnosia is so much bigger than that. It's really a whole family of disorders, and they can show up in some truly startling ways. We're talking about the inability to recognize faces or sounds, or even to recognize your own body parts. I mean, get this. This is a real case from the medical literature. A man is in a courtroom, but he can't recognize his own lawyer. He walks right up to the other side's lawyer and starts spilling confidential details about the case. This isn't just being forgetful. It's a very specific failure to recognize a face. What do we call that? That is prosopagnosia, also known as face blindness. The patient can see the nose, the eyes, the mouth. All the individual features are perceived. But the brain can't put them together into that unique pattern that says, "That's my wife," or "That's my doctor." The damage is usually in a specific spot called the fusiform gyrus. So what do these patients do? They become detectives, using other clues like a person's voice, their walk, or the way they dress to figure out who they're talking to. Now, get ready for something that's even more mind-bending and can be incredibly tough for everyone involved. Imagine your patient has a huge stroke on the right side of their brain, leaving their entire left side paralyzed. But when you ask them to raise that left arm and they can't, They just insist everything is fine. This is anosognosia, a lack of insight into your own deficit. And I cannot stress this enough, this is not psychological denial. It's a neurological problem. Damage to the right parietal lobe, which manages our internal map of our own body, makes it impossible for the brain to even perceive the deficit. You can see how this creates huge safety risks, right? A patient might try to stand up, completely unaware that their legs simply won't work. So as you can see, agnosia can look like other things. That means a huge part of your job is being a good detective, building a solid differential diagnosis and knowing how to rule things out. How can you be sure you're not just looking at an aphasia or a simple sensory problem? This table, this is your secret weapon, both in the clinic and on your exams. The whole principle is multimodal testing. You have to test recognition through different senses to pinpoint exactly where the problem is. For example, how do you tell visual agnosia apart from anemic aphasia, which is a word-finding problem? Simple. You move from sight to touch. The patient with agnosia can name the object now, but the patient with aphasia is still stuck. By systematically isolating the deficit, you get to the right answer. All right, let's pull all of this together. For anyone studying for boards or just wanting to lock this in for your clinical rotations, this is the rapid-fire review. Let's do it. Okay, let's lock in these essentials. The core concept of agnosia is sensation without recognition. For visual agnosia, remember the difference between apperceptive and associative, and remember to test it by asking the patient to draw. Prosopagnosia is face blindness. Think fusiform gyrus. Anosognosia is that lack of insight, and you'll see it a lot with right-sided strokes. And your number one job is always to make sure you've ruled out aphasia or a primary sensory problem first. Okay, you've heard the lecture, now let's see if it's stuck. I'm going to throw a few quick clinical vignettes at you. Let's see if you can nail the diagnosis. Ready? So think about it. The problem is in the hearing domain, but it's not hearing loss and it's not a language issue. It's about recognizing a sound. What do we call it when there's a lack of awareness of a deficit? It's a failure of the brain's ability to perceive itself. This one's pretty fascinating. They can see and recognize individual landmarks, but they can't put them together to form a mental map. All right, let's see how you did. Case 1 is auditory agnosia. Case 2 is a classic presentation of anosognosia. And the third, a more specific one, is topographignosia. These are exactly the kinds of recognition failures you need to have on your radar in neurology. So, in the end, agnosia is so much more than a collection of bizarre clinical syndromes. It's a window, a really profound window into how the brain works. It teaches us that seeing isn't just about our eyes, and hearing isn't just about our ears. Recognition is an active process, a complex construction, and when parts of that machinery break down, a person's entire reality can change. It's really something to think about.